All right, you said proximal humerus fractures are really common. Let's get into that. Let's bring a patient in to examine.
Perfect.
So, failure to thrive, I'm afraid. Even an orthopedist can see that. Proximal humerus fractures occur, generally speaking, in 4 parts.
Okay.
Okay? The shaft is one part.
Mm-hmm.
The humeral head is another part. The lesser tuberosity, to which the subscap is attached, is a third part. And the fourth part is the greater tuberosity, to which 3 of the 4 rotator cuff tendons are attached: supraspinatus, infraspinatus, and teres minor. So when the proximal humerus fractures, and there are parts, those are the parts that they break into. Okay? And that's because of the muscle forces on the shoulder. Again, 80% of proximal humerus fractures we treat without surgery. 80%. So they need a sling, they need hand exercises, they need some pain medicine, and they need follow-up within a week.
With orthopedics.
With orthopedics. If it's non-displaced, it's probably fairly reasonable if they're more comfortable following up with their primary care physician. But even a little bit of displacement can become more over the first few weeks. So usually orthopedic surgeon. Fracture dislocation in the elderly or even in younger person, you almost never can relocate in the emergency room, so don't try.
Okay.
A fracture, the reason is because what dislocates is the head.
Okay.
The way in which we relocate the head is by pulling on the arm.
That
Well,
aren't
now
attached to the
the
humeral
arm
head.
is not attached to the head, and so unless they're very cachectic, you can't feel the humeral head to even work it with your own hand to get it back in, whether it's in the front or the back. So fracture dislocation, I tell our residents, we don't even really try. We shouldn't. I'm not saying we haven't.
Right.
But we probably shouldn't put the patient through that. They should come to the operating room, and it's usually not emergent, but it's usually something that we should try to get to within a day.
Okay.
One other thing. For all shoulder dislocations and proximal humerus fractures, we should know whether or not their axillary nerve is working. It's the most commonly injured nerve in a shoulder dislocation or fracture. You can palpate their lateral skin and ask them if they feel this or not. That's one way. But the best way, the more reliable way, is to do this. You put one hand on their elbow and you put your other hand on their posterior shoulder.
Okay.
And you ask them to focus on their elbow. So
Okay.
they're not thinking about their shoulder, which is so sore. And you ask them to push your hand backward. So back into the bed, back toward the pillow, back toward the wall. And what you're doing is you're feeling it to see if their posterior deltoid is firing. There's almost no other muscle that actually extends your shoulder, and this is extension of your shoulder, this is flexion of your shoulder. The posterior deltoid posteriorly extends the shoulder, and you can feel it. That's a much more reliable exam finding than sensory.
Oh, okay.
And it usually the patient tolerates it.
Yeah. I'm going to try it.
Yep.